this session essentially deals with. So, as we understand, despite advances in our understanding of disease pathogenesis as well as the advances in treatment, the patient outcomes have not commensurately improved. And part of it is attributable to our improper understanding of the complete pathogenesis and also to the strategies in which we are targeting these diseases. And that is where lifestyle occupies a very central role. Despite its significant contribution to improvement in patient outcomes, it often ends up being neglected. But the good news is that the importance is increasingly being recognized. The presidential oration by Dr. Dhammanan gave a beautiful overview of how these non-pharmacological and lifestyle-related changes may have an impact on rheumatic diseases. The ULAR itself in 2021 came up with detailed recommendations on the impact and the assessment of lifestyle in rheumatic diseases. They gave an overview of 6 basic lifestyle-related parameters, including diet, exercise, smoking, alcohol, and weight reduction and work participation in all 7 rheumatic diseases, including RA, SPA, PSA, SLE. So, lifestyle may actually be the holy grail that we are looking for as far as the treatment in rheumatic diseases is concerned. So, with this overview, I would like this to set the ball rolling for this session. The outline of the session would be, we'll start first with a grand round on lifestyle and rheumatic diseases, which will be presented by Dr. Sakir. This would be followed by a final verdict and expert comment by Dr. Partha Sarkar. Then we'll have a talk on how comorbidities actually influence outcome in rheumatic diseases by Dr. Kumar Kundu. And finally, we'll end the session by a talk on the controversial topic of how patients with JI on biologics can actually will be predictors of better transition to adulthood. So without further ado, I hand it over to the chairpersons.
Thank you. So without losing any further time, I will request Dr. Shakir Ahmed from KIMS Bhubaneswar to talk on the grand round on lifestyle and RMD, rheumatic muscular disorders. Dr. Shakir, please.
Thank you, Chairperson. I would like to thank the Iracon organizing committee for inviting me for this talk. So my topic here is, please do not move the mouse there. I can start from here. So I am here to talk on climate change, lifestyles and rheumatic musculoskeletal diseases. These are my disclosures, and some of the slides have been made by a senior resident from KIMS. I have included a few. So grand round usually should have one case, we discuss the outcomes, and then there is a in-depth feedback from the masters in the field. But in case of something like climate change, the case is community based. We have to take the entire community as a case and then study how it responds to the stimulus and what are the outcomes. And the best example I could find was Olm's country from Minnesota, and because the data on rheumatoid arthritis from this has been available since 1955. All patients meeting the older ACR criteria for rheumatoid arthritis have been included if they were diagnosed with rheumatoid arthritis after 55. So this was the initial data that they had presented, and we can, when I was a student, initial Kelly was showing this figure and showing the incidence of rheumatoid arthritis is coming down. But then another edition came, and the next edition showed the next study, and here we can see that gradually there is rise. It is no longer falling. So why is this happening? If we look at the data in detail, we can see seropositive rheumatoid arthritis is actually declining, but seronegative rheumatoid arthritis is increasing. What may be the cause? One cause is association with smoking. We know that smoking is associated predominantly with seropositive disease, and across the world, in India, in the United States, everywhere smoking has come down. So this may be one factor why the seropositive disease has come down. Parallelly, obesity has increased, and obesity is a risk factor for both seropositive as well as seronegative disease. With this background in mind, they did another analysis of the Minnesota cohort, and they can see if the patient did not have obesity, the predicted outcome would be like this. Hope you can see the pointer. So this was the dotted line. The dotted line represents the predicted outcome had they maintained the same BMI. But since there was an increase in BMI, there was also an increase in the incidence of rheumatoid arthritis. So this is indirect proof. Let us come to another study. You might have heard of the nurses' health study. In the United States, all the nurses were given an option to fill in their personal health data and anonymized and report every 3 to 6 monthly. So they would voluntarily every year at least 4 times give their own health information, and you could find out what new diseases they are developing. There was initial health study started in 1960s and then a second nurses health study. And when we look at that, we can see the data from the nurses health study 2, it showed increased prevalence or increased incidence of rheumatoid arthritis when there was increased BMI. If the BMI is 25 to 30, it is 1.7, and when the BMI is more than 30, the hazard risk goes to 1.9. And similarly, this was all cases, and if you look exclusively at younger patients, so younger patients, even the data from nurses health study 1 was showing a significant risk factor. So younger people who are developing obesity are at higher risk of developing rheumatoid arthritis. Unfortunately, data is very limited. This is the case part, and now I'd like to come to the discussion part. So discussion, as my topic entitles, I would cover what is climate change, is it going to affect rheumatology practice, and what lifestyle is going to affect rheumatological practice. So if you look at the world temperature over last 20,000 years since the alleged birth of Jesus Christ, we can see there has been some fluctuation over the last the 1800 years, and then suddenly it has risen unexpectedly. That might be a mild word, and there has been data from across different agencies who monitor the temperature across the world. The average mean temperature of Earth has increased by at least 1 degree Celsius over the last 180 years. This has been unprecedented in history of humankind. And we already have seen the evidence. It was there in the news recently, the floods in Bangalore, the unheard of temperatures found in London. London had reached temperatures of 40 degrees, which was what we were seeing in Lucknow when we were residents. And what is this leading to? Besides others, it is leading to emergence and re-emergence of various infectious diseases. The biggest one was there recently, that was COVID. And if you look at the predictions before the onset of COVID, this was the prediction by WHO that what are the emerging infectious diseases or re-emerging. We can see it's a plethora of diseases, and we can see there are organisms like which cause diarrhea, which cause there's chikungunya was there. We know chikungunya can lead to arthritis. The last speaker has told us in reactive arthritis how there is one infection leading to onset of reactive arthritis. And we have all seen cases of post-COVID arthritis. So this was a review done by our group. This was an international group, and we tried to define the entity code post-COVID reactive arthritis. And we could see it was mostly above 45 years, affecting small joints. Thankfully, it was resolving. So what we could find out in COVID arthritis, if you treat initially, most of them will not become chronic. But with the next pandemic, we may not be so lucky. All the viruses have a tendency of causing arthralgia. Some of them may cause arthritis, and they may persist. And other autoimmune manifestations also may be precipitated. So what are the changes and how do these changes? Suppose we are talking of smoke. How is smoke going to affect our chances of developing rheumatoid arthritis? I am keeping the discussion simple to just rheumatoid arthritis. All of us would have seen this film, so the newer generation might have seen this one instead. So what is happening is that always the twins are different. They look alike, but they always behave differently. So what is there? That genetics is same, but the epigenetics and the environment that makes the difference to the phenotypic expression. It has been shown in lab mice also. You take the mice with the same genetic background, you give them the same food, but you give them different doses of certain epigenetic modifier, and you can see the overall weight of the mouse is different, the skin texture, the color, everything becomes different. So epigenetics play a much greater role than possibly we expect. There are very mechanisms. I will not go into details, but if you know DNA is coiled and it is supercoiled. First it is wound around the histones, and when it is coiled, it cannot be translated. The DNA has to open up. So first thing is the DNA methylation. If the DNA is methylated, if the DNA is methylated, it forms a closed structure. If it is acetylated, it forms an open structure. And ultimately, we get, this is a very famous landscape. We have all seen this somewhere. So, what is there in our genes, it gets modified by our environment, the toxins, the food we have, the microbiota. Every hour, every minute, over the years, it is being modified, and we develop a different landscape. This is called an epigenetic landscape. Your grandmother might not have smoked, but many of our grandparents were exposed to, especially their grandmothers would have been exposed to smoke from a chula. And that may affect me. Suppose when my grandmother had my mother in her womb, she might have been exposed to the environment pollutants, the chula smoke. And that might have caused epigenetic changes in her germinal, the germ cells, the ova. And that I would inherit, and I would get those epigenetic changes because of the exposure of my grandmother. So we say in India the women are not smoking, but women are still getting rheumatoid arthritis. This is one possible hypothesis, the chula smoke, and obviously we know the air pollution, how much it is there, especially in the big cities. That may be itself a risk factor that will be known maybe 2 generations from now. So this was, I had expected this earlier. When it is methylated, it is all tight packed, the gene cannot be translated, and when it is unmethylated, it opens up and the genes can, this is the on-off signal. So we call it DNA methylation, other one is the histone acetylation. Then talking about other risk factors. One of the most important ingredients in our meal is salt. We cannot cook bread, we cannot cook biscuit without salt. You can give it a try if you have interest in baking. But salt is so much important for our taste, texture, that we are taking excess of salt. The recommendation is that the WHO says you take less than 5 gram table salt. But American Heart Association says you should take even 1/3 of that. I think what we are doing is we are taking almost double of that. And that is associated with reduced potassium intake, especially fresh fruits and all, we are hardly having sufficient. And how is this potassium affecting? This potassium is a very important molecule for inflammasome activation. When sodium goes up, sodium and potassium are always balancing each other. So one goes up, the other will go down. And because of the low potassium levels, there is a high tendency of activation of the inflammasome. If you have not seen the inflammasome, it is a very beautiful structure, but it causes a lot of damage. This is the 3-dimensional picture. It causes activation of pro-IL-1, it cleaves pro-IL-1 into interleukin-1. And interleukin-1 starts the inflammation, there is accelerated atherosclerosis. So that is one of the reasons why we say salt causes increased atherosclerosis. And this is not just, same mechanism will be there for rheumatic disease, same mechanism will be there for coronary artery disease. We have looked at different aspects of the metabolic syndrome in patients having various rheumatic diseases. But this is a topic to be covered by Professor Kundu. I'll not go into details. Then there are these things, what we call adipokines, leptins, omentins. The fatter we are, the more adipose tissue we have more of these adipokines. I'll not go into details, but all of these adipokines have a direct link to inflammation. They are related to joint erosions, they are related to accelerated atherosclerosis, and etc. etc. So the more, this may be one reason why obesity is leading to increased incidence of rheumatoid arthritis, and we expect the same for other autoimmune diseases. So to summarize, that Indian data is very limited. We do not have longitudinal data, but what we have seen from the United States data is that initially, maybe because of the reduced smoking, the incidence of rheumatoid arthritis was coming down, and now gradually it is increasing, especially seronegative disease. For us, important is we have changed from chula to gas, but still air pollution is a major concern, and the effects may be seen 1 generation or 2 generations later. Mechanisms we have talked about, different epigenetic changes, the innate immune activation, the potassium goes down, inflammasome activation, and in case of obesity, the adipokines. So that is all I have to say. And while I was going to the Chappan Bazaar, I could see I could find a new thing that was Gathia chart. I don't know if Gathia chart causes Gathia or it prevents Gathia, but then there is a link between our lifestyle and the disease we are going to get. We are also having a Orissa meet in the 10th and 11th of December. Any one of you interested are most welcome to attend. With this, I would like to hand it back to the chairperson. Thank you.
Okay, good afternoon, ladies and gentlemen. And Dr. Shakir has dwelt on mainly the effect of climate on different rheumatic diseases, mainly the pathogenesis, genetics, and metabolomics, all these things, the effect. So from that very serious note, I will talk a few things about So rheumatic and musculoskeletal diseases comprise a significant proportion of mortality and morbidity all over the world, which affects the patient quality of life to a great extent. While medical research has taken the giant strides in developing pharmacotherapy for rheumatic diseases, there are increasing requests from the patient, health professionals and policymakers for more information on how changes in lifestyle alongside drugs may prevent progression of RMDs and associated disabilities. So I am presenting here the 2021 EULA recommendation regarding the lifestyle behaviors and work participation to prevent progression of RMDs. Usually there is 5 overarching principles and 18 recommendations were there. The overarching principles are just lifestyle improvements complement medical treatment and do not replace it. Lifestyle improvements are essential part of RMD management. WHO recommendations for healthy lifestyles are applicable to RMDs also. Lifestyle recommendations for each individual with RMD depend on factors such as age, sex, health condition, pregnancies and comorbidities. And there should be regular discussion between people with RMDs and health professionals regarding lifestyle factors. Now few recommendations regarding exercise. Exercise is beneficial for many health outcomes including but not limited to RMD symptoms and progression. People with RMD should exercise because of the benefits on pain, function and quality of life. People with RMD should avoid physical activity and avoid physical inactivity. They should engage in regular exercise according to their abilities. People with RMD should perform both aerobic and strengthening exercise aiming for at least moderate intensity. People with RMD should be advised that exercise is safe and it is never too late to start exercising. Though these days so many catastrophes are happening, so before doing any exercise, the regular checkup of not regular, the initial total checkup, mainly for the elderly, has to be done whether there is any basic problems in this, and exercise depends on that. Exercise can be performed in different settings, alone or in groups. There is slight benefit favoring group exercises over exercises performed alone. People with osteoarthritis and axial spondyloarthritis should be specially encouraged to exercise, as it is particularly beneficial for disease-related outcome. Diet is healthy, balanced diet is integral to the lifestyle improvement for people with RMDs. People with RMDs should be informed that consuming specific food types is unlikely to have large benefits for RMDs outcome. Though we have a list of certain foods like don't take junk foods, take a common, that is the leafy vegetables, fruits, then the cereals, nuts, these are beneficial. But report is not in favor of any specific food. Regarding the weight, people with RMDs should aim for a healthy weight. People with RMDs who are overweight or obese should work with health professionals to achieve controlled and intentional weight loss. Then alcohol. Alcohol consumption in people with RMDs should be discussed together with the health professional and the patients. People with RMDs can be assured that a low level of alcohol consumption won't negatively affect mostly. People with RA and gouts mainly, in these two cases, there may be more flare if it is moderate to a severe amount of alcohol consumption. Now coming to the smoking, people with RMDs should be encouraged to stop smoking and be informed that smoking is detrimental to symptoms, function, disease activity, disease progression, and occurrence of comorbidities in all rheumatic diseases. People with RA and health professionals should be aware that smoking may affect disease-modifying anti-rheumatic drug treatment response also. Regarding work participation may have beneficial effects on health outcomes of people with RMDs, and they should receive attention within healthcare consultation. So my take-home message is, defining recommendation based on evidence for lifestyle changes is the first step in improving disease outcomes in patients of RMDs. Exercise recommendation highlight the safety and benefits of exercise on pain, disability, particularly on patients of osteoarthritis and spondyloarthritis. Diet and weight recommendation emphasize the importance of a healthy, balanced diet coupled with efforts to maintain a healthy weight. Smokers should be supported to quit, and patients of RA and gout are to be warned regarding flares upon taking moderate alcohol consumption. Lifestyle changes coupled with pharmacotherapy is the way forward for overall morbidity and mortality reduction in rheumatic diseases. Thank you for your hearing. So that's all about this lifestyle changes altogether, the basic aspects and some recommendations. So I will ask the next speakers to come on the stage.
Thank you, sir. Thank you. We'll have the next talk by Dr. Iracon from Kolkata, how comorbidities influence outcome of rheumatic diseases.
Good afternoon, everybody. At the outset, I must say that I am thankful to the organizers for giving me a chance to use this podium in front of this 1/3 full of the hall. Now, I am basically a physician with a inclination to rheumatology, subject of rheumatology. That's why I'll not give my lecture with full of data, cohorts, tables, and etc. You will not feel bored. It is with some telegraphic message, some comments, some quotes. The topic of my discussion is how comorbidities influence outcome of rheumatic disease. The definition of comorbidity is comorbidity is a medical condition that coexists along with the disease of interest. Suppose it is the most common disease at the outset is rheumatoid. What is multimorbidity? Many student has got some different idea about it, but it is the coexistence of two or more chronic disease in the same individual, where comorbidity focuses on the index disease, like rheumatoid arthritis with anemia or diabetes. It will focus on rheumatoid arthritis, addressing to the co-occurrence of any distinct additional entities. In multimorbidity, no index disease is defined and all morbidities are regarded of equal importance. This is the picture, is not going viral. Few days back, the President of Royal College of Edinburgh came to Calcutta 7 days back. He had delivered a lecture. I have seen it in many of the papers publishing for United Kingdom. I was present there. He is delivering the lecture of Aging India. I got a slide there 7 days back. It is his slide of multimorbidity in an aged person all over the world. It's a beautiful slide. So I am indebted to him. He thinks multimorbidity in such a way. 9 boxes are there. So 2 boxes are open. I don't know which will come here. Suppose COVID may come here. The burden of comorbidity. There are so many books in the market. Recently, the significant negative impact, everybody knows there is some negative impact of comorbidity on the course of the rheumatic disease and other inflammatory disease. A number of comorbidity may have individual impact on the course of the rheumatic disease in individual patient and lead to the therapeutic option of both diseases. That means one have got one comorbidity, so he wants 2 modes of treatment, 2 groups of drugs to be given. If comorbidities are diagnosed early, the negative impact is significantly reduced. Comorbidities, everywhere it is written, are a cause of poor prognosis of the basic disease. The comorbidity greatly influences patient's quality of life. That means I want to say, effectiveness of treatment, what I want to give the drug, I may not give that, and the prognosis of the primary disease. It is very easy to understand. As may be expected, the more comorbidity the patient has, more drug we have to apply, and the prognosis you can easily imagine. The greater the utilization of health services, the greater the societal and personal cost, and the poorer the quality of life, and the most important, the hospital stay is increased. This is the most important part. So comorbidity increases your cost and prognosis and everything and quality of life. And perioperative complication, morbidity and mortality. It adds comparable complexity to the patient care, making the treat to target strategy a failure. So treat to target strategy is really at stake when the comorbidity is there, more challenging. Suppose AMI is silent in diabetes, we all know it may be silent in rheumatoid arthritis and very difficult to diagnose. So the comorbidity, one has the greater interference with treatment hospitalization, also correlate with worse response to treatment and deterioration of the functional capacity. Pulmonary and cardiac comorbidity are most often associated with mortality, but the most important is the last line, work disability of a rheumatic disease is more strongly associated with depression. Many papers are coming. The depression is one of the half an hour back before entering this hall, one of the doctor who knows me told me he is suffering from one disease, doctor attending here as a rheumatic disease, and suddenly she saw she had got psoriasis 6 months back. She is now in their depression, no other comorbidity. Just now it happened. So the division of comorbidity, disease related to rheumatic disease which is full of inflammation and cytokines, suppose it is rheumatoid arthritis along with anemia, it is known as coexisting. And the disease independent of the underlying disease like diabetes, heart disease and others, it is coincidental. So comorbidity has got 2 divisions recently as coexisting and coincidental. By clinical studies, most common comorbidity, what we should know in rheumatic disease are hypertension, hypercholesterolemia, cardiovascular disease, may not be ranked 1 to 2, obesity and diabetes. There is a full host of these comorbidities in literature and in internet. You all know this. But the common one is cardiovascular disease. Suppose there is I have focused rheumatoid arthritis, ant-spawn, gout, lupus and psoriatic. The common 5 groups comes to our clinic. The cardiovascular disease, lung disease, cardiovascular disease means even atrial fibrillation, congestive failure are not a rare complication of rheumatoid arthritis. Once before I could not make the diagnosis of congestive failure, who was suffering from rheumatoid arthritis because I could not take the history, I could not get the time. Lung disease, kidney disease and eye disease. Infection, suppose a patient of rheumatic disease having infection, suppose suddenly you discover he has got hemoptysis and infection of tuberculosis, so the treatment is different. Anti-tubercular drug are the chance of more toxic to the liver along with the DMARD, everybody knows. Then carcinoma, then diabetes and the bone health is the most important comorbidity along with the rheumatic disease like osteoporosis. Fatigue, one should not ignore this, depression, whatever I was telling, skin disease and the sleep issue. Many of our patients in our hospital opening tells, we have got Iracon night, so there is sleep issues. So comorbidities is one after another. The common one are cardiovascular disease, lung and pleural disease, bone disease, osteoporosis, infection, different types of infection in different disease. Where there is more immunosuppression, more infection is there. Depression and malignancy. But one should not ignore these one, liver disease, kidney disease, GI tract disease, diabetes and hypothyroid. All these are added features. So like one example of comorbidity, estimated relation of to rheumatoid arthritis, the comorbidity high association, high group of is anemia, osteoporosis and any bacterial infection. Medium group is acute myocardial infarction, heart failure, congestive failure, GI ulceration. Low means stroke. So rheumatoid arthritis patient having CVA has got low association, low comorbidity. No relation like appendicitis. So all these comorbidities are due to rheumatoid activity, NSAID treatment, TNF alpha inhibition treatment, corticosteroid treatment and chronic pain added with poor physical activity, muscular weakness, obesity and depression. Cardiovascular disease in systemic rheumatic disease presented important comorbidity seen even in the absence of traditional risk factor. In a patient like me and you, the traditional risk factors are insulin resistance, dyslipidemia, smoking and hypertension. These are not present in your rheumatoid arthritis patient, but they are having or suffering from cardiovascular risk factor and adding to the morbidity and mortality burden. Yet, cardiovascular disease unfortunately remain poorly addressed in our chamber. I have asked many of our friends whether he is or my students whether they are rheumatologists or not. We are ignorant about the cardiovascular disease, the rheumatological disease patients are suffering from. Osteoporosis and cardiovascular disease are among the commonest reported comorbidity in spondyloarthropathy which should be addressed. This is a slide because it is Iracon, that's why I made it. I do not know this. Measuring and recording comorbidity, and this is burden. This is basically for research purpose. Most frequently used assessment tool for comorbidity in rheumatic disease are Charlson Comorbidity Index. This is for your examination, DM final exam or nothing like that. The Rheumatic Disease Comorbidity Index, RDCI, or Multimorbidity Index. These indices has been developed primarily for the research purpose, but you may use it for clinical purpose. Recently, Dr. Guleria came to our city and I had a deliberation with him. I asked him, how do you see all these three corona infection or COVID infection? He told me in a very simple line. The first infection in 2020, I think it is an infection of respiratory tract infection in a non-vaccinated person. It is his comment. The second one, he told, it is the infection of a vaccinated person. And third one is the disease of comorbidities. It is his word. I have written there are comorbidities in rheumatic diseases predisposed to severe COVID-19 infection and even death, especially in the third wave. So in the conclusion, I may be allowed to say that comorbidities should be carefully evaluated and treated in patients with all rheumatic disease. We must evaluate this, otherwise prognosis will be disturbed. Comorbidities jeopardize the achievement of treat-to-target goals and the barrier of optimal treatment outcome. Rheumatologists are the health assistants or the health professional and the patients play a significant role in detecting all these comorbidities. Thank you for your patient hearing. Yes.
Good afternoon. So just a change of gear. We are going to now discuss about children with JAA, juvenile idiopathic arthritis. So we all know, we all have used biologics for the adult rheumatic diseases, because whenever it comes to the children, there are a lot of controversies and about can we give these biologics to these children, and does it cause more infection, more long-term outcome, all those things. Still we have a lot of concerns about giving biologics to children. So what in the next 15 minutes, what I'm going to talk to you about one thing, because you all are adult rheumatologists, what I want to emphasize is JA is not RA. That's the first thing. Second thing, what are the biologics in JA we use and what is the evidence for using that? Then the last question, now we are giving biologics to JA. Can it really predict the long-term outcome of JA? Can we stop sending all our children for follow-up to you? Can we use that with JA so that you don't see any children when they become adulthood in the follow-up? So as I said, JA is not RA because JA is not one disease, RA is one disease. So here there comes 7 phenotypes, especially oligoarthritis, polyarthritis, enthesitis-related arthritis, psoriatic arthritis, systemic onset JA. So we have different sessions in this IRA for each and every disease. But children, we have only one disease, JA, which comprises 7 different subgroups. So when you look into this, the seropositive RA, that is rheumatoid factor positive JA, is equivalent to the adult RA, which is about 5 to 8%. Then we have seronegative, early onset, especially polyarticular are of negative and oligo and systemic JA. Little older children, more than 6 years old, usually we call them as, you call us juvenile ankylosing spondylitis. We call them as psoriatic arthritis or enthesitis-related arthritis, because the spondyloarthritis, the inflammation of the spine, will not happen till the children are 20 years old. So ankylosing spondylitis or juvenile ankylosing spondylitis is usually the adult disease, doesn't happen in children. So these are the group of drugs which from early days, starting from 1960s till now, the list is keep on going. So when you want to talk about biologics, this etanercept is the first biologic which is approved for children in 2000. So we can divide the treatment of JA before 2000 and after 2000. So each new, you know all about these drugs. We have TNF inhibition 4 drugs, IL-6 1 drug, and T-cell deactivation, abatacept, anakinra, IL-1 and canakinumab. This is also IL-1. So here you can see the FDA indications and the EMA indications for approval for when we can use. So when you look into this slide, you can see that tocilizumab, more than 1 year, still more than 1 year we can use. Most of our drugs are more than 2 years. So when you look into that, that's what they usually, systemic J is the one which present very early, remaining and all for the little older children. And you know about the dosage and how frequently you give, it is almost same like in the adults. So when will you use biologics? That's a question now. So we talked about, so we have some guidelines from 2019 from American ACR guidelines we have. This is for non-systemic polyarthritis, sacritis and enthesitis. So what they say is, non-systemic means they should not have any systemic features, risk factors whenever they have rheumatoid factor positivity or joint damage when you see the child. So then we have a juvenile disease activity index score, that is called JADA score. If it is more than 2.5, it is called high disease activity, less than 2.5 is low disease activity. Why do they divided that is because depends on the child. So it is not uniform, the treatment is not uniform. You have to start high treatment if the disease activity score is high and if they have some predictors, bad predictors. So this is what they said. So they said that anybody with polyarthritis, you should start on methotrexate very early. You should not give only NSAID, wait and watch and then you start. So when you have polyarthritis, you start on methotrexate. Methotrexate is better than sulfasalazine or triple drug therapy. We don't have anything. So this is the methotrexate is the one you have to start. Then you follow them. If they have a low disease activity, you continue them on methotrexate. But if you have moderate high disease activity, you have to add biologic. Biologic, again, they don't have very big preference. TNF alpha comes first. So they say about 3 months, if there is no improvement with methotrexate, we should go to TNF alpha blockers. And if there is still no response, you can change to another TNF alpha blocker, or you can change the drug like IL-6, you can change the drug, different drug also. They also said that all the children should continue on intra-articular glucocorticoid should be given, and very important thing, the bridging therapy, steroids, should not be given in any child more than 3 months old. So steroid should be used as a bridging therapy. We should not use that as like a disease modifying agent. Okay. Then in 2021, again they talked about new guidelines for systemic JA, oligoarticular JA, it came. Again what they said that in children with oligoarthritis, here you don't need to start methotrexate initially. You can give either intra-articular corticosteroids or NSAIDs. If there is no response, you go to methotrexate again. If there is no response on methotrexate for 3 months, then you can think of giving biologics. So it's what oligoarthritis management algorithm showed. For systemic JA, this is what little they differ. What they say is, first you look for presence of MAS is there or not. If there is MAS, they want to go to IL-1 blocker followed by glucocorticoids. If there is no MAS, still they want to give IL-1 as an important thing. If they have residual arthritis, arthritis is the predominant. So whether it is a systemic symptoms predominant or arthritis predominant. If there is arthritis predominant, you can try our conventional DMRs like methotrexate. If it does not work, you go to biologics. Biologics again, if the systemic symptoms are very high, you go for IL-1 or IL-6. If arthritic predominant, you go for your TNF alpha blockers. That's what they said. So predictors, I said, severe arthritis, symmetrical disease, already hip is involved, wrist is involved, rheumatoid factor. These are the predictors of outcome in JA. So now in JA also, we are thinking of treating to target phenomenon. So what you see is, if the child has got very high disease activity initially, we need to give aggressive treatment. If the child has got low to moderate, you can start on methotrexate, wait and go high. Our final target should be remission of medication. You should stop the medication, put the disease under control and give them a good quality of life. Okay, so these are the few complications of JA which were not treated properly. You all see buttoner deformity, wrist, ulnar deviation. This is one boy with HLA-B27 which is already, he is almost 19 years, he already started to develop all the hump and knee arthritis, flexion deformity. All those things will happen if you don't treat JA adequately. So, question, can biologics predict a long-term outcome in JA? So, I have divided for this talk, I divided the methotrexate era is before 2000. We all used this type of phones in 2000. Now we are in the biologic era, we have started using smartphones. So, this is this era. So, what happens? So, how methotrexate came to in JA management? So, adult RA, we already from 1980s we have started using methotrexate more and more. But in children, this is the first trial which is published in NEJM in 1992. Children who are on NSAIDs who are not responding, they gave methotrexate. So methotrexate, they gave 2 doses, 10 mg per kg or 5 mg per kg. What they found, they gave it for 127. So what they found out, children on low dose methotrexate, there is a very good improvement. So low dose means 10 mg per kilogram. So based on that, they said that methotrexate works. Second landmark paper was published in 1992. So here they said subcutaneous methotrexate works better in children with arthritis. That to dose, they divided the dose into 15 mg per kg and the high dose is 30 mg per kg. You can see here the response is very good in 15 mg per kg itself. So what they concluded is the methotrexate subcutaneously 15 mg per meter square is better. No need to increase the dose to 30 mg per meter square. So this, based on these 2 landmark trials, methotrexate came as a standard of care. But what happened? So we started to treat with methotrexate. What happened to the children who are treated with methotrexate alone or with other things? So this is a paper which looked into the disease outcome and the course, published in Journal of Rheumatology. This is from Canada, 3 centers in Canada. They followed up all the patients who were treated with methotrexate and other conventional DMRs. So what they found out is they have 392 patients. They have a lot of polyarticular RF negative compared to the systemic. So you can see here the probability of remission at 5 years at the disease onset is very, very low in polyarticular RF positive, but in systemic and in the other things, it is still more. Even at 10 years, you can see here almost 25 to 50% of the children, they don't have attained remission. They also said that lot of children went for arthroplasty also. That means disease was persisting, the joints are getting damaged, and they also, lot of children were in severely functional disability also. So they said that even though with methotrexate, there is a slight increase in the children getting better, but that is not enough. That's what they said in 2002. Another one, this is from US. This paper is from US, with the methotrexate era. So health status of patients with JRA at 1 and 5 years after diagnosis, 14 centers in US from 1992 to 1997, 700 children. So they have used everything, hydroxychloroquine, sulfasalazine and methotrexate. They found out that still significant number of patients, 60 to 80% of patients still taking drugs. So they also found out that their growth is affected, especially when they are systemic, they have joint space narrowing, they have a lot of school function, a lot of patients, and global function is also affected when they are treated with methotrexate alone. So what happens in 2022? This is a paper which looked into how with all the biologicals this. You can see here the ACR 70 response, almost 55 to 70% of children are active, achieve ACR 70 response, and you can also see the flare rates are very low when you compare to the placebo. Infection, we are all very much worried about infection. So here is a meta-analysis which is published. They looked into 19 trials, out of which 11 were given for TNF inhibitors, 3 with IL-6 and for 6 with IL-1 inhibitors and abatacept. You can see here they found out there is not significant, the relative risk is only 1.13 increase when you use biologics compared to methotrexate. So it is not like really saying that it is very high because of infection, is not true. Again, this is one of the biggest registry from Germany, something called Biker registry. So they followed almost 4,000 children who were treated with biologics, and